This is Heart Rhythm TV, and I'm Daniel Alyesh. Welcome to a special report on PFA Biophysics for the Clinician. And for that reason, I'm joined today by Dr. Will Sauer, Arrhythmia Service, Brigham and William Women's Hospital. Welcome.
Thanks, Sam.
And then Dr. Chris Porterfield, also of Aurora Denver Cardiology and the University of Colorado.
Thank you. Good to be here.
So, the impetus for this discussion is, the era of PFA has been upon us for some time here in the U.S. with excellent uptake. But we as an EP community are now in the position to evaluate newer technologies. And the PFA algorithms are proprietary. And for that reason, it can be somewhat under a veil, our understanding of what is actually happening when we push the button and treat our patients. And so as we move forward evaluating these novel technologies, foundational understanding of PFA biophysics is critical. So as an overview of what our plan is for our discussion, we'll talk about waveform basics, understanding voltage, shape, packet size, and delivery, catheter design, the importance and what that means for delivery of PFA, lesion characteristics, thermal effects, the effects of dual energy, and then some clinical manifestations as it applies to PFA biophysics, skeletal muscles, the effects on the esophagus, microbubbles, the impact of scar and vessels. So without further ado, we'll get started with our first point here, waveform basics. This schematic comes from a very nice article by Atul Verma, published in Circ EP, where it breaks down all these critical components of PFA biophysics. And I'll pose this first point of discussion to Will Sauer. Can you go over the components of a PFA waveform and maybe kind of a little bit of the clinical impact, which we'll elaborate on further in our discussion?
Yeah, thanks. I think that at its core, PFA is very high voltage, 1500 volts, sometimes more, direct current voltage. And if we go back in the history of ablation, we kind of did PFA, in like the late 80s. Mel Scheinman hooked up a quad to a monophasic defibrillator and delivered 200 joules through the quad electrodes and got AV block in that circumstance. And that is PFA in a way. It's a pretty brutal form of PFA, and there's barotrauma, and there's a lot of side effects which push the field towards RF ablation, because RF ablation turned out to be a more precise and safer approach at that time. Now, what we're doing is kind of the same thing, except we're delivering that high voltage in a very, very short microsecond window. And not only do we deliver the 1500 volts when we put that energy out there, we're doing it many times, and we're doing it in a biphasic way. It gets a little confusing because when you push the button, let's say you're doing a PFA case, you'll just hear a noise and you'll see a artifact delivered. What's happening is a certain amount of packets are delivered. There's a period of kind of off time where it's resting, then it's delivered again, and delivered again. And so now we're talking about cycles, packets, pulse duration, activation duration, and the delivery rate. And we got all these different variables that as electrophysiologists we have no control over. All we can do is push a button. But we have to trust that the animal studies and the clinical studies that the manufacturers used, what they're trying to do is deliver the most specific destruction to myocytes without causing heating of those electrodes. And so I think a lot of the companies have this proprietary information about their waveform because they've done a lot of work to try to make it as safe as possible or as effective as possible. So there's a lot of terms out there, and in this slide we're going over some of them. The slide that you're showing here shows monophasic pulses, biphasic cycles, and multiple packets that are delivered. I don't want to take too much time over that, but we have a lot of different terms that can get confusing, but in the end, we're delivering energy in pulsed, very microsecond pulsed waves to try to minimize heating, minimize barotrauma and arcing, and try to specifically cause electroporation that renders the targeted tissue electrically inert.
Thank you very much. Thank you for that great summary and all you've done in biophysics for us in EP. Yeah, I think it was a very interesting read, trying to understand, some of what goes into a waveform. Some of the things that I also read were there are trade-offs with skeletal muscle recruitment that you can see depending on how you construct your waveform. Delays between delivering packets can allow the tissue to rest to avoid thermal effects, but it lengthens the duration of the ablation. And so these are all a little different with each product that we're evaluating, but all go into the recipe. And I think improving our understanding honestly unlocks our understanding as EPs, because I think in the world of RF, we like to toy with, power, duration, irrigant, contact force, and that's been kind of, at least for now, lifted from us. So, well, thank you for that great discussion. Moving on to catheter design. Chris, I'll pose this question to you. So you have monopolar, bipolar, circular catheters, focal tip. Talk to us a little bit about what goes into a catheter design and the importance of monopolar versus bipolar designs.
Sure. When I first started working with this, and Will probably experienced the same thing, is we started with potatoes, turnips, looking at really the how the energy was delivered. And it was interesting to me that not all the catheters were delivering the same energy in the same manner. Although you had a basket and a circular catheter, and you would expect that energy delivery is going to be applied, in a biphasic manner from electrode to electrode, and it typically goes outward from the catheter, not inward. And so you get these outward lesions, and you're expecting all of these to be created equal. There's some interesting phenomena that occur, and you see these patterns of the electrical current. In this picture, it's a really nice picture of showing a lasso catheter in bipolar, monopolar current. And they were showing what happens. And these had like a target of, I think, 4 millimeter depth or something like that. And they looked at these catheters. And then if you go to the subsequent slide, now we have really a buffet of different catheters. And it's hard for us clinicians, I know all of us have been playing with PFA now, and it's hard for us to exactly understand what happens to the tissue with each of these catheters. There have been a number of studies looking at this. I've done a number of animal studies looking at different catheters, depth with either monophasic or biphasic therapies, trying to really understand how deep. We're seeing around 4 to 6 millimeters. We do see this interesting cage effect with the larger baskets. The cage effect is a central clearing where you do not have any current passing through, but you get this outer band. So the central tissue is not really affected. And it's probably okay for pulmonary veins. So pulmonary veins are really, we're wanting the outer tissue, not the inner vein where blood pool is. So it's kind of an interesting phenomenon that we've started seeing more and more of as we're getting to this, I don't like to say it, but one-shot technology. All of these one-shot catheters are applying typically, in a biphasic manner, looking at how far we can push the envelope efficiently with current to get, enough of an injury to be permanently irreversible damage to the cells. So not all the catheters do it in the same way. Some are very efficient at delivering energy. Some are less efficient, more energy. The the monophasic catheters have to, they're having to give more energy to get same effect. They have more thermal effect. So there's more heating with the monophasic catheters. We're trying to push the limits of that because we want to be in the ventricular space soon, and trying to get that 8 mm plus thickness that we all want more of. So I don't know, it's going to be a really interesting time for PFA, but it's I don't know if you've seen this, but I think there are 27 catheter designs that are out there. I mean, in a while, we're going to have a buffet menu to say, oh, I want this shape, that shape, this, so it's going to be interesting to see how that happens over the next few years.
I listened to a very interesting podcast. It's called The Problem of Choice, which is, a certain number of choices are very helpful for people. But when you get to something like 5, 6, 7, 10, 12 choices, human psychology it creates more anxiety and indecision than anything else. So hopefully we don't get there. We're not there. But just to summarize a little bit about what's out there. So we're all familiar with the pentaspline catheter, Farapulse, a bipolar biphasic catheter, so bipolar ablating between the splines. PulseSelect Medtronic, also a bipolar biphasic. Affera coming online is a monopolar biphasic basket catheter. And then the focal catheters are also going to be monopolar biphasic. Monopolar being ablation performed between a distal source as well as the tip of the catheter. My understanding in that circumstance is that you're going to get maybe a little more skeletal muscle recruitment with a monopolar setup. Although time will tell what that looks like. And, people are trying to figure out in the AFib world how to do this under sedation. And that's kind of one of the limitations that we're seeing.
Even with the, I just did, as of about 20 minutes ago, a procedural with conscious sedation with the pentaspline catheter. I don't recommend it. Even with as much sedation as you can give, it still has quite a lot of coughing and muscle recruitment. So I don't know if you tried it yet or not, but it's in a patient that did not want general anesthesia. I'm not in favor of it. So.
I haven't gone that route.
Yeah, no, I think the no general anesthesia is fine if you're not going to use electroanatomical mapping, but the patients are going to move, and so that can be frustrating. But yeah, I think in Europe they're doing it a little bit more, just using like fluoroscopy and the wire-based FARAWAVE.
So let's shift our discussion now to how does PFA form a lesion, and then how does a lesion evolve over time? I think this is distinct from thermal ablation and part of the special sauce of PFA. So, Will, I'll pose this question to you. Can you describe PFA lesions acutely, how they form and how they evolve over time?
So the basis of the lesion is the electroporation that occurs at the cellular level. And so, myocytes are relatively large cells, and with that electroporation, they lose their ability to conduct electricity from cell to cell. Now, if the electroporation, occurs in such a way that the cellular repair mechanisms can repair that membrane, then the lesion will be reversible. And that's the main issue that we face with PFA, is that when we do a voltage map, say after PFA, there's going to be a large area that appears to be electrically inert, but is capable of repairing. Now, when we compare that to RF, we have some clues. We can give adenosine. We have a waiting period. We can do some tricks. Loss of capture, these kind of things. Those tricks, they don't really pertain to PFA. So the only thing we can do is sort of give additional lesions. It's a little bit of a misunderstanding. When we're giving additional applications of pulse field energy, it's not so much to create a deeper lesion. it's really to minimize the reversible component of the lesion. So the lesion's there. Now, if you were to look, under a microscope, another difference that you'll see is that it's just a very well demarcated lesion after it matures. I don't know of any examples where we have lesion maturity with PFA having a larger lesion. Typically, as time goes on, the lesions regress. In radiofrequency ablation, that's a little bit different. There are examples where we can have lesion maturity with scarring in and slightly larger lesions, paradoxically, because I know that we always face pulmonary vein reconnection or a pathway that comes back. And of course, that's lesion regression. But there is a component of lesion progression with RF applications that you just don't see with PFA.
Mm-hmm. Well, thank you. I think that's one of the cruxes of the issue, right, is the zone of reversibility around the rim of a PFA lesion. And, I think there are data now for the importance of contact and electrode contact and some contact force for PFA lesions. And the idea behind that may be to reduce the size of that zone of reversibility. But it is difficult to understand in the context of, really, when we're used to be able to use all these other techniques, now we have a stunning effect. And having been part of a couple of the PFA clinical trials, we were doing a case the other day and they say, oh, let's do our 20-minute waiting period.
Right.
And I think to myself, right, the reversibility of PFA, correct me if I'm wrong, is around a couple hours. Where you'll see some regression and then further on more down the line. So I think that 20-minute waiting period is really an RF holdover, right? I mean, is that really?
Yeah, I agree. I will say remapping has sometimes been, most of the times it doesn't give me information. It just gives me confirmatory information. But every now and then outside the left superior pulmonary vein, I'll realize, well, maybe I didn't have good contact as I thought I did. And so in terms of remapping and trying to understand whether or not you need to give additional applications, I don't think it needs to be 20 minutes. I think you could do that in 1 minute because you either got it or you didn't. And if you got it, then the waiting period is, as you said, 3 hours. It's not going to be practical. So yeah, it's worth looking and making sure that you got what you need. But I don't think that we can apply the same waiting periods or other tricks that we were using with RF ablation.
So, I think this is a very interesting space now to move into, to talk about lesion formation and to talk also about the combination of PF and RF applied sequentially. These data are from a tool Verma as well. And I think, Will, you're also doing some work in this space. The sequential aspect or a nature of performing lesions does yield a change. And so I wanted to ask you to talk about this concept and to project forward what this means for lesion delivery.
Yeah, this was a great study where the investigators delivered RF applications, 50 watts for 10 seconds, for example, and then delivered a pulse field applications on top of that. And the lesions were bigger, and your kind of common sense would say, well, that doesn't make sense, because if I do 50 watts for 10 seconds and then I do a PFA, whichever mode or whichever energy modality gives you the deepest lesion, that's where you're set. The reason why it's additive is because of a couple of reasons. Number one, when you deliver the RF, you're heating the tissue. Hot tissue conducts electricity better, so you're getting more current delivery to the targeted tissue just by that alone. On top of that, with the resistive heating, there's a little bit of edema, and that edema helps us with PFA because it allows for more, a little bit of osmotic pressure on the cells, which may lower the susceptibility to irreversibility. And it also is introducing just more ions to go through those membranes. So it's kind of a clever way of building on RF lesions. Now, we don't really know what the right recipe is. Do we deliver, low power, long duration to try to get deeper? I think this is going to be really important for VT. I think that, for AFib, we've sort of landed on these on the technology that we're in, and we're getting some pretty good results. The main problem with PFA and VT is that, as Chris mentioned, is the depth is just not there, and this might be a way to sort of get us to that. So it's interesting, and I'm definitely interested in the topic, and we've looked at this a little bit, and we have similar results to this.
No, I think this is what I found very interesting about this too is the center of the lesion appeared to be coagulative necrosis, so more thermal, and then the rim was more hyperemic, and more of a PFA type lesion. So the argument is your center is going to be, more thermal, and then the safety or the outer rim may be around you may still have the safety of PFA, although this was only a few pigs in the ventricle. Really a lot more to learn in this space, but I think you're right. The ventricle, we need to get deeper. The atrium, I think there are areas where there are challenging substrates and we're kind of limited, but for pulmonary vein isolation, we have a fairly good early algorithm there. Before we move on to our next point, I wanted to also talk about delivering PFA lesions. We talked about the corpus apoptosis. It's not coagulative necrosis. The extracellular matrix is intact in these lesions. But what are some of the parameters? Because PFA lesions can become thermal. So what causes that? And what do we have to look out for? And I guess, Chris, I'll put that question to you here.
Sure. There's a lot to this, and a lot that we're learning kind of on the fly with these. When the waveforms are established, we discussed already this kind of biphasic or multiphasic approach with the short kind of square versus sinusoidal delivery of these packets. We really, with current, you get heat, and there is heat with this energy. The way we get around it is by having delay. And so the delay, you apply these short, either biphasic or monophasic sequences. The monophasic, especially monophasic unipolar sequences, with a longer sequence, with a unipolar configuration, you'll have more thermal energy. There's going to just be more heating. With the biphasic, it's a very, I like to say multiphasic instead of biphasic, but biphasic short pulses with a fairly long delay between the delivery to allow for this dissipation of thermal energy. We did, and there have been a number of studies. We did it in pigs with, really trying to get as much detailed thermal measurements along the esophagus. There have been a few studies that I think may have been on one of your slides, but looking at the esophagus, even doing pulse field on the esophagus to see what happens to the tissue. Unfortunately, the esophagus is usually spared from any type of thermal injury from PFA. Even if there is a lesion created, it does not provide further necrotic change.
Yes,
so
very, very, very important point, and it is on one of my other slides. But yeah.
So it's it's an interesting method, and I think when we go to the monophasic, longer train, going into a unipolar configuration, we will be seeing more heat, more thermal. That will be the only caveat, but we'll be in the ventricle. The only thing we're going to worry about maybe is we'll be still worrying about the coronary, but we won't be worrying as much because we've done thermal injury with RF for quite some time in that space.
Will, I'm going to bring this question back to you. Actually, in this study, a tool study here, I think they had 2 or 3 steam pops, which was surprising. I mean, it was 50 watts for 10 seconds in combination with a relatively non-aggressive PFA sequence as well. They achieve fairly good lesion depths though with the combo. Now it's a pig ventricle, you know, one of the, for me, whenever I'm ablating the ventricle and I'm thinking to myself, and I'm worried about a steam pop, I'm on the RVOT free well or something, I'm just saying, I'm thinking to myself, when can I get PFA so I can not worry about this? But this sequential technique, there appears to have been some steam pops. So can you comment on that and why you think that occurred?
Well, I mean, so one of the surprises I think with PFA is that there is heating. When I was first introduced to PFA, it was marketed as a non-thermal way to destroy cardiac tissue. But there definitely does have heating. And if you, let's say you deliver RF lesions and you get to 99 degrees, Celsius just underneath the catheter tip, and then you deliver a high voltage, you might get just enough to get it over there. The main issue with heating at the for the PFA electrodes, I don't think we're going to need to worry about steam pops too much. I guess I want to just, maybe I have to look at that data a little bit closer. I'm more worried about char and coagulum formation, like the old days when we didn't have cooled electrodes, because that can cause a stroke. That can be devastating for some people. And I just think that the steam pop issue is, we're going to work around that, because it's just never going to get to 100 degrees unless we're delivering RF or unless we're doing something crazy on top of it. So the heating of the electrode, the main issue, I think, is going to be coagulum, going to be char, and potential for neurovascular events.
Absolutely. So, speaking of which, PFA Biophysics delivering PFA energy with the pentasalon catheter close to a Watchman. This is a very interesting video that you shared with me. So I'll play it and have you explain what you're doing here and some of your findings.
So for our viewers or listeners, what we're showing here is an experiment that we performed where we used a pentaspline catheter, we delivered energy, and we have an electrode actually touching one of the metal struts of the Watchman, or the left atrial appendage occlusion device. We use a potato model in our benchtop studies. And when we deliver the energy and we're touching metal, you can see arcing. You can actually physically see the flashes of light. We're conducting a series of experiments. One of the things we've noticed is when we see this, the lesions are much, much smaller. And why is that? Because the energy has now been dissipated into a light show. It's no longer being focused into the targeted tissue. I think this is going to be a rare event. I think you got to be touching the metal or really close to the metal, or maybe in between two poles in a bipolar configuration, perhaps. You might be able to see this if you have that cobra formation that occurs with this catheter, because you can have electrodes touch other electrodes, and that's sort of what we're seeing with arcing. Thankfully, we have some safety mechanisms that help prevent delivery of energy in that circumstance. But metal affects the flow of radio frequency energy. It also affects how PFA energy is delivered. And so it's something that's going to come up as we get close to pacing leads or stents. And it's one of the things I'm interested in studying.
Well, thank you for that. You sent me this video shortly after I did a PFA in a Watchman patient. My understanding, at least in my discussions with the company, was that if it's endothelialized, you're going to be okay. They don't recommend doing it within the 3 months, and I absolutely did not do that. And I'm watching this on ice. Definitely did not see this effect. And I think it's the 303 error where the metal contact alert that disables the PFA, and those safety mechanisms I think are very helpful. But again, very, very interesting figure and an interesting space to continue to learn more in.
Yeah, I mean, I think that an endothelialized left atrial appendage occlusion device is safe to ablate near. I would say that you want to avoid touching metal when you're delivering energy, just because it's able to conduct and it could have unpredictable effects. I think that's the lesson here. And more and more we encounter these things. But it's similar to RF ablation. It's, we also have to be careful with metallic exposure near RF electrodes. So just building on that.
So this next slide is a kind of a summary of everything we've discussed, which is, all the different PFA parameters: voltage, waveform, frequency, packets, packet duration, delay, and how that affects different clinical metrics down the line. Lesion size, muscle contraction, skeletal muscle contraction, risk of microbubbles, which we'll get into, arcing, like we just saw. And so, essentially, I'll put this question to you, Will. If you're able to kind of summarize these biophysical parameters of a PFA waveform, how do they clinically affect, in the broad sense, lesion size, skeletal muscle recruitment, and some of the things that we worry about during a PFA procedure?
Well, I mean, so I think that there's a lot of things that just make sense. Like, for example, the more voltage you deliver, the more barotrauma you're going to have, and the more arcing potential you can have. And so I think the companies were wise to try to find the right voltage for getting safety. Again, as clinicians, we don't have control over that. We really just have control over contact and number of lesions. So when we look at this and we decide on voltage, waveform, we're looking at, I guess, number of packets or we don't have a lot of control. So, and that might be a good thing to start out with. I'm hoping that we're going to have some programmability, and when I want to deliver a lesion that's near the His bundle, I want a different voltage or different waveform. So maybe someday we can do that. I guess what I would say is that a lot of preclinical studies went into developing the waveform, the voltage, the frequency, packet duration. And if you looked at some of the original clinical papers, there really was a difference in pulmonary vein reconnection and pulmonary vein isolation. So it's not voodoo. There really is something to the science there. And so that's why we're handed this tool that has already had the preclinical evidence to guide us. I guess the only other thing I would say is that in the experiments that I've seen and performed, there's a limit. You could, if you give 2 applications, well, giving a third, does it give you a deeper lesion or a more permanent lesion? Probably not. If it does a fourth, does a fifth? There's definitely a plateau effect, and so that's also something to consider. And as we stack more and more lesions on top of each other, you'll have heating, and then you're going to run into that heating problem with the coagulum and char. And so I guess I would just be careful with delivering lesions and stacking them on top of each other.
I think we as an EP community have really put a lot of trust, quite frankly, in a lot of the pre-work that was done to develop these algorithms, probably more so than we ever have. I think, and that's something the reason why we did this segment is we want EPs to think critically as they evaluate the newer technology, because if they have this basis for understanding what goes into a waveform, what impacts it, the limits of thermal application, and understanding monopolar versus bipolar, I think this can be foundational for evaluating what you're going to bring in and how you're going to apply it.
Yeah, I agree. I mean, I think with radio frequency energy, I mean, we took a certain, there's preclinical evidence that got us to the 450 kilohertz number, and I think that we rely on that, and I think it's a similar analogy here where we rely on a proprietary waveform or sequence, and then we trust based on the clinical evidence the safety and efficacy of the tools that we're given. But I'm with you. I want to learn more about it. I want to, can I tweak it? There's an engineer in me where I feel like I gotta make it, right for the patient, Chris, what do you think?
100%. We're kind of similar minded. I like to be able to control, or at least understand what I'm delivering. The employees who are hitting the button, I'm like, well, how much voltage did I just apply? Where, and they're trained to say a certain number, and I'm like, well, how do we know that? And is there a way that my catheter is slightly, I'm rotating the catheter one way or the other? Is this something that's, it's when it's out of control? It's like when you're flying on a plane, you're completely trusting something that makes the engineer and all of us CPs a little wary, but we do have to trust a little bit of it.
So, I'm going to move the discussion now to tissue-specific effects, because I think this is also some of the promise of PFA, which has been realized, and that's the lack of collateral damage, or the minimizing of collateral damage, and the tissue specificity for cardiac myocyte. So Chris, I'm going to put this question to you. PFA's effects, and I'll start with the positive. PFA's effects on other tissues such as the esophagus, or myelinated nerves, or ganglionic plexuses, and pulmonary veins as blood vessels. Can you comment on, I know I asked you to talk about a lot of things at once, but each one of those tissues, what are we seeing biophysically, and why is it beneficial to pursue this energy source relative to thermal?
Yeah, I think this is always what, as an electrophysiology community, we want the most efficient energy source that's the safest. And so when looking at thermal versus current-based technology, the two things that always give us pause are the phrenic nerve and the esophagus. We're always, with radio frequency, we're always looking, even with cryo, and I never did a lot of cryo, but we always were pacing the phrenic nerve, looking to see if we had a loss of capture. The interesting part with current-based, with pulse field, it appears that this low conductive myelin sheath of the phrenic nerve spares it, even though we will see temporary or transient effect. Within 3 to 5 minutes, the effect is back, and the phrenic nerve is no longer affected. It's been looked at in many studies and well demonstrated in the article that you have mentioned. The esophagus, or let's go back to ganglionic plexus. The ganglionic plexi are different. They're not, they don't have the same structure as the phrenic nerve. And so the nerve cell bodies in the autonomic ganglia don't have myelin. And so they're not protected, and they're actually very sensitive to PFA, or energy. So that's a good thing for us. That's what we want. We want those nerves to be very easily susceptible to injury, where the phrenic nerve is spared. The esophagus, the same thing. I find this study to be really interesting. When they actually performed ablation PFA on the actual esophagus, saw transmural lesions and then regression of those lesions, which is fascinating to see that the entire transmural thickness was affected, but then healed. And so another win for us who are in the left atrium. Blood vessels also tend to be less burdened, although we see the coronary spasm effect and the spasticity of the vessel. Although it doesn't occur every time, but we see it, and we often preventatively give medications to prevent spasm. So it's all in all, it's interesting because we're fortunate to have that sparing of the tissues that we don't want. Whereas some of the other effects, which we'll talk about with hemolysis and some of the microbubbles in a little bit, we'll discuss more of.
No, a very nice summary, Chris. I think it's interesting. The myelin is protective, which is helpful. I think there are a lot of reports of stunning of the phrenic nerve that made us all really nervous. And I think there's only one, at least when I saw it manifest, of one kind of persistent phrenic injury. The rest all recovered, and which is far better than thermal ablation. Not perfect, but far better. At least as far as the esophagus goes, one thing that I thought was interesting in reading this paper from 2020, an Asian paper with the PFA applied directly over the esophagus, was it's the whole extracellular matrix phenomenon, which is an intact extracellular matrix in a tissue that regenerates. Those stem cells will go in there and grow and fill that space again. At least that was my reading and understanding, versus cardiac myocytes, which are not that regenerative. So you take advantage of that difference in sparing critical structures. Some of the promise with PFA, and then also with pulmonary veins, because you don't have coagulative band-like coagulative necrosis and band-like fibrosis, you have a lot less pulmonary vein stenosis or no pulmonary vein stenosis, a small decrease maybe in the diameter of pulmonary veins, but really no pulmonary vein stenosis, even when applying PFA within the vein, which kind of unlocks another ability for PFA. Will, any other comments from your perspective?
Yeah, I think that there's a couple of preclinical studies that really were very encouraging. I want to segue into the microbubbles that we see and maybe the red blood cell lysis that we see, because those same studies told me that red blood cells are less sensitive than myocytes, and now we're seeing maybe not, right?
Yeah.
So I want to, I just want to be, I'm thrilled that we're not seeing esophageal injury. I mean, I think that if it ever happens, everyone is going to hear about it, of course, but I have a fair amount of healthy skepticism when someone says this energy source works better on this tissue as opposed to this tissue, because I now see it didn't hold true for the hemolysis thing.
So yeah, that's a very important point, and I think we'll shift our discussion now. We're playing an ICE image, ICE-guided PFA, which I think in the current construct is the way to go. You got to guide each one of your lesions with ICE. But if you've guided your lesions with ICE, you've seen this phenomenon before, the PFA microbubble phenomenon. And so, will you describe the ICE image for the viewers and listeners, and then talk a little bit about what is the mechanism behind this?
Yeah, I apologize for the right-left invert here. This is a patient of mine who did fine, by the way, 0 complications. But when you see this, it's certainly startling to see this shower of bubbles come as you're delivering your pulse field energy. Now, what does this represent? Well, that echogenicity that's coming through is likely gas, because gas bubbles that you see will look exactly like that. It probably explains the reason why there's a signal for increased asymptomatic cerebral emboli. I think that there might be some barotrauma. There might be the lysed red blood cells, and I think if you have enough of this, you could have hemoglobinuria and renal insufficiency. So I guess I'm not sure exactly what it is. I don't see it on every pulse. Sometimes I'll see it if there's that 303 error that you were talking about, where it'll deliver one pulse and it realizes that there's arcing. But when you see this, it's a little concerning.
I agree, and my understanding, at least from the reading, is PFA microbubbles, the energy can cause a little bit of nitrogen to be released into the blood pool and then reabsorbed. They claim in transit. And the more aggressive your waveform, the larger these PFA microbubbles can be, and actually the more clinically significant they can be. But it's not, it's jarring to see this. Now, this is a very interesting point that you make, which is that we're trading, PFA has been billed as the savior for a long time. And I think we're trading some reassurances, maybe for some uncertainty, and for us also some newer concerns like vasospasm, which I have yet to experience. But you hear the stories, as well as hemolysis, because of the exquisite sensitivity that we're finding now of red blood cells to PFA when PFA is applied into the blood pool as opposed to into the tissue. And from what I'm reading, not all PFA catheters and waveforms are created equally for this. Others have more hemolysis than others. But I'll pose my question to Chris too. Projecting forward, microbubbles and hemolysis. What's the way forward for us in the PFA space as far as our understanding and our mitigation of it?
I think, with hemolysis, it's unique to less contact. Certain waveforms could lead to more hemolysis than others. But I think it's understanding, in a dose-dependent manner, the more PFA lesions, the more likely you're going to have hemolysis. I think one of the studies was 54 lesions above 54 was the cutoff for the Pintus line. But you can see it even with less or more. I have not technically seen it in my cases, but I'm not ordering, I'm not looking at, all these parameters, just going off frank urinalysis, looking for if patients have an inability to void or renal failure. But I haven't seen that. Have not seen it in clinical practice. But I do understand that there probably is a dose-related point where if you're getting to a number of more than your typical case, then to start looking out for hemolysis. For the these cerebral events are very worrisome to me, and if it's truly related to the microbubbles or if it's coagulum, that's I think to be determined. I know in Advent and Pulsed AF, they showed all of these cerebral lesions on MRI, but they didn't do MRI on all the patients. And so we haven't really looked as deep as probably we should and need to look in this technology to see what's going on cerebrally. I am worried about that. I'm worried about catheter design. One of the issues that we see, and from a more of a biodesign background that I have, it's the cathode interface that can cause arcing, can cause coagulum, and so I've seen it in vivo, and I'm a little worried about that part of it. So hopefully, as we get to second and third generation, we'll see a lot less of this. But that's kind of where I'm currently interested.
Well, thank you all for this great discussion on PFA biophysics for the clinician. And hopefully this can, lend to foundational understanding in this space. And, the tools are coming more and more, and we all need to think critically about how we evaluate each new offering with a foundation in biophysics. So thank you for joining me.
Thank you, Dan.
Thanks, Dan.
And thank you all for tuning in to Arrhythm TV.